All right. Hi, Cindy. So nice to see you. It's great. I get to see people I haven't seen in a long time. Some of you that I don't know. I'm Zaina Grifoni. We have our physical therapy Pilates studio in San Rafael, California. So thank you again for being here as you're all logging in. Great. I think we could get started. And if people come in later, I wrote them a little note. So yeah, I will give you the floor.
Okay, I'm going to now share my PowerPoint slides made for you. So today's basically challenging conversation is, okay, so I'm going to do this forever. And what is the risk? What's the benefit, short and long term? And then I added for all of you, what can a Pilates instructor do? So sharing information, increasing, reinforcing motivation. That's a huge part because, flash in the pan, oh, this is a good idea. I think I'll jump on that bandwagon, but then you jump off it because it gets boring to just take good care of yourself. So it's our job to continuously inspire and reinfuse that loving self-care attention and time and energy it takes to do it. And then encourage women when they make progress. So we chatted last time briefly about the evolutionary biology of menopause as the framework for really understanding the big picture. And so, in short, breastfeeding babies, lactation is a natural occurring, biologically, evolutionarily selected for state of very low estrogen. We mobilize more calcium from bone, brilliant for infant survival, making strong bones and giving protein to babies. And we also increase our liver synthesis production of fats or lipids for milk. So that's evolutionarily, in my very strong opinion, why we have these built-in aspects, which are, of course, bad when we get older, if they are inexorable and continue for the rest of our lives. It results in low bone mass, osteoporosis, and also in frailty, more heart disease, all the things we touched upon last time. What I didn't show you last time was just a quick picture. And again, this is a very old, I've been trying to get an update, but this was made as projections in 1996. But I think it's still valuable until I take the time to actually generate my own improved slide. This was from a slide set back in the late 90s in talks I gave on bone loss. But in any event, what you see, what's important is you see that in 1960, we didn't really have a lot of women in that over 75 white and teal hatch mark band. So I looked at the year I was born, 1951. There weren't a whole lot of old ladies around. By the time I was a young professor at the University of Arizona in the mid 90s, okay, we're now seeing by the population in the millions of women over 75. And so when I arrived, my 2-year sabbatical in Arizona, I was shocked to see women in wheelchairs and walkers because my patient population, my view is San Francisco. Well, we have potholes in the sidewalk as well as our streets, and we got hills. And so we don't have a lot of frail little old ladies out and about. But when you're in Scottsdale, Arizona, you see that population of frail elderly. You see the, electric carts at the grocery stores with the, claw that women can use to grab things off the shelf. So it made a big impact on me. And I was teaching public health graduate courses in health challenges for women and children. And so that was my perspective in the course, was to start with the very old, because this is the result of our healthcare system today. But I think what's very impactful is when you look, we have more than 90 million women over 75 in the United States. And if you look at the health condition of those women, it's pretty lousy. And, the homework assignment we talked about last time, think of 5 women over 80 in whose bodies you'd be happy to live. That's a pretty hard task for most of us. We really can't come up with 5 80-something-year-old women that look pretty vigorous with it and not so, riddled with bad arthritis or unstable gait, or maybe can't remember the grocery list kind of quality of life issues. So anyway, now to your questions. So someone asked about the relationship between progesterone and estradiol. So progestation is really what progesterone is designed to do in our menstrual cycles. So estrogen itself in young women, our average is about 100 estradiol. If you just look at blood tests every day of the month and divide by 30, they would add up to about 100 being your average daily estrogen. Anyone who's been pregnant, mostly once you get over the nausea part of pregnancy, you feel pretty good. It's pretty rare that depression is ever a big problem during pregnancy. It's after pregnancy when this abrupt decline of estrogen happens. So progesterone is in fact associated with low mood. Now there's a lot of creative talk about progesterone. There are some naturopath chiropractic types that give women progesterone if they're blue. In randomized double-blinded clinical trials, that does not work. And in fact, for about 10% of women, and this was the way the question was actually asked, the women with the vulnerable brain, it actually can throw you into a depression. So I'm very careful knowing that I'm more likely to get those women referred to me because I take the time with specialty populations. So generally we use progesterone to keep the lining thin, the uterine lining. So we generally only use it in women who have not had a hysterectomy in menopause. So the other aspect about progesterone, yes, it has been associated with suicidal ideation and exacerbation of PMS or premenstrual dysphoric disorder. And sadly, there is a slightly higher suicide rate in women in what we call the luteal phase, which is the phase of our cycle when we're young and ovulating, with that cyst of ovulation that makes progesterone. So these are all data that do speak for caution with progesterone for that. As I say again, I emphasize this just to say it's a small number, but it's an important percentage. 1 in 10 of us has potentially this negative reaction. So the beautiful thing is we do separate out these hormones in virtually every product in the United States, with the exception of one. Once women are happy on progesterone, which is most of us, there is an oral product now called Bijuva. It has both estradiol, 1 milligram, and 100 milligrams of progesterone, natural bioidentical progesterone. It's made by Therapeutics MD, invented by a doctor who's a gynecologist and his wife an internist. So, I love that product for women who've been on birth control pills and just want something real easy. Step off my birth control island as a young woman and step over to a daily pill that does the trick, abolishes hot flashes, keeps my vagina moist and elastic, and I feel fine. So there are many women who use that product. They're thrilled that it's available now in their insurance in the United States. I'm pretty sure it's in the EU and also Great Britain, Australia, and New Zealand. The reason we use FDA approved products is to be sure that they're well absorbed. So to get FDA approval, to have something actually in a pharmacy covered by insurance, that has to undergo very rigorous testing to know how that hormone is absorbed into your body, what is the peak level that it attains, and what is the duration of effect. And unfortunately, progesterone creams do not prevent uterine cancer in women with a uterus the way known FDA-approved administration of progesterone does. Now, I have a few patients who are very sensitive to progesterone by mouth. They take it through the vagina. Again, that's off-label. That's an individualized thing. Since they're taking it through the vagina, they don't need the typical 100 milligrams we give women by mouth because they're not destroying it in the stomach. You destroy about half of it in the stomach. I'll show you a slide of that later. But in any event, these are all concerns that the clinician should address. And so I use my compounding pharmacist, Peter Koshland, wonderful evidence-based guy who also has independent product testing through an independent lab to assure both quality and purity and amount. So anyway, I do have some patients who get compounded 50 milligram vaginal little suppositories of progesterone, and it works beautifully. But all of these off-label things, it's very important that a clinician periodically makes sure that we're not missing anything. So that's where the annual pap smear helps us pick up random cells that may indicate uterine lining overgrowth, and a periodic ultrasound, pelvic ultrasound. Again, that's not the cheapest way to take care of people, but it's individualizing and making sure that we're not missing anything that would create a problem. So I just want to show you, we think of something on my skin, no big deal, but the skin is actually designed to keep stuff out of your body. And so that's why these gels and creams made by compounding pharmacies, they cannot put in the research and development years and dollars and do all the testing to make sure that all of the product is going through the layers of the skin, getting down to that capillary plexus you see at the very bottom of this slide. So this is where, in fact, the estradiol, or if you still want to be a progesterone believer, it has to get down here. So what the pharmaceutical industry figured out, whether it's the patch that acts as the reservoir itself, or your skin that becomes a reservoir, it's kind of a beautiful thing when you put the estradiol gels on your thigh. And I always say thigh, not your arms, please, because we draw our blood from our arms. And so if we're going to look at blood levels as a guide, that messes up the assay. Obviously, you're going to have a higher concentration in your arm. So oral estrogen, and I have another slide that follows this one. So this is kind of abstract, but this is the lumen, or the inside of where you're absorbing that 100 milligram progesterone, let's say, in your gut. It's going to turn into, actually this is estradiol, but the progesterone, by the time it gets here, it's at about half of its level. When it comes to estradiol, this fairly high level of estrogen, if we took it by mouth, enters the liver and creates what's called first pass effects. So what does that mean to you and me? Whoop, the slide is out of order, but anyway, first pass effects increase clotting factors, increase hormone binding proteins, increase thyroid hormone binding proteins. So it can perturb what would have otherwise been a balanced system. So that's why I'm a big advocate for the vast majority of us, especially in asking the question about the pause, having been off hormones for a while. It's much safer to restore hormones through the skin because we're not going to increase risk of forming a blood clot, which is the major concern as we age. It's not huge if it's been 2 or 3 or 5 years. But again, if we have a safer route, why not travel that route? So I'm pretty big on transdermal or transvaginal to reduce risk. So we'll get back to this because the other slide will be coming up in a sec. So is there a recommended time or set of conditions that benefit women from taking hormones? So I put very simply, the sooner we start, the better with respect to the brain and heart. Now, beautifully, we can catch up for cardiovascular health. We have statins that can actually reverse a little bit of plaque. If you know other women who've had an event or a husband who had an event, often they're put on statins to lower cholesterol even further. So these are things that our need for statins is actually decreased if we are well estrogenized, because that favors a healthier ratio. Remember, I told you in the low estrogen state of breastfeeding, we actually synthesize more fat. Well, you synthesize more fat when you're in the low estrogen state of menopause. So the more years we've maybe been, packing the fat inside my arteries, the more likely you are to have deposited some atherosclerotic plaque. But for a lot of women, their mood is just so low when they're estrogen deficient. They beg for hormones and they receive them, but it's often their depression and their psychiatrist that put them on the estradiol, and then they see their gynecologist just to monitor everything. Hot flashes basically are a signal that your brain is not happy, doesn't have enough estrogen. So these are all very important things. Yeah, we can tough it out, but that's actually not good for us. That may be good for a football team if your foot hurts, but it's not good for women. And then this is your question. If someone has been in menopause for many years, is it still an option to start taking hormone replacement therapy to prevent other medical conditions such as high cholesterol and blood pressure? And I said very simply, being evidence-based, statins really are the therapy for very high cholesterol. And estrogen, if we add it to a woman who's hypertensive, it really does not significantly lower her blood pressure to the degree that we would like to see, like the 130/80 or less. So it will help long-term to be on some estrogen in addition to your statin and in addition to your antihypertensives. But as I said, and I put that in the slide with all these words to be very clear, that estrogen does not treat existing heart disease. It's pretty amazing how well it prevents heart disease, but we don't play catch-up ball by adding estrogen to an already atherosclerotic situation. I put in smaller print here, assessment of current cardiovascular health prior to initiating oral estrogen for sure is important. The transdermal is safer, we talked about that already, to use in general for reasons related to effects of taking estrogen by mouth, blood clots, strokes, as compared to the natural route through the skin or vagina. Another kind of similar kind of mirror question, is there an upper age at which it's not recommended to start HRT if you've not taken it before? So blanket statement, vaginal, local only, at any age is fine. And I do have some wonderful, sexually active, late 70s, early 80-year-olds that I've been the doc to bring their vagina back to life, and they're happy. Assessing cardiovascular status really should be done before anything beyond a very low dose of systemic transdermal estradiol is given. And I do have some women who have seen me for consultation who want systemic estrogen, partly because they feel like they're forgetting things. And I say, it may not help your memory if you're already having memory issues, but it will help hot flashes. So, there are 15% of women for whom hot flashes never go away, by the way. So there are other reasons. And the big point I'm just answering kind of delicately and precisely is systemic use of estrogen must be carefully addressed on an individual basis. And it's actually very easy to address and assess things, but very few doctors have that in their hip pocket, like, yes, I'm going to do this, that, and the other, and make sure we're fine. Here's that slide that I thought I had put right after the other kind of abstract picture, but this just shows estrogen therapy drug delivery. So through the mouth, this is much more like the way our brains work. Like there's your esophagus, it goes down into your stomach, and then there's your stomach, and then whoop, the estrogen goes over into your liver, and they're showing how it's actually little estrogen diddy dots in your circulation. It's in your bloodstream. But this first pass hepatic metabolism creates more blood clots and strokes in any population. If you look at hundreds of thousands of women, in any individual woman, like say, take me, I'm healthy, I have normal blood pressure, I have normal cholesterol, I exercise, I'm low risk. My parents died at old ages, not of heart disease. You know, my dad was 92. You know, so I'm very blessed. But I still use transdermal estradiol because I'm 70, soon to be 71. So I just know in my age group, the incidence of deep vein thrombosis in the calf in my age group is about 1 in 40. That's a lot, you know, especially if you're going to sit on airplanes and long flights. Of course, I wear support hose. I mean, I do a lot of things that most people don't do, but still, you know, I don't know that treating myself as an exception would give you the best health. So I also feel that if I do what's optimal, what we know scientifically is likely to be best, if I still have a complication, well, I did my best. So that's why I'm pretty rigorous, even with my own self-care, to use transdermal. And when I was 65, I went from my oral estradiol and progestin to the patch. So I do practice what I preach. And I use the patch that I change it twice a week. So just to let you see, again, I want to show you the data on which I have my opinions. So this slide is kind of neat because it has conjugated equine estrogens, that's the Women's Health Initiative Premarin, and oral estradiol compared, because one of the first studies that was done after Women's Health Initiative came out compared head-to-head oral estradiol and oral conjugated equine estrogens. And this is just looking at cholesterol, basically. HDL cholesterol is the healthy, good kind. And what you see, in fact, you see more good HDL in the women on the conjugated equine estrogens. You see pretty good on oral estradiol too. And then here's transdermal estradiol. Less of a good effect. They're still better than women not on these products. But I just think this is where, you know, okay, I'm not going to use oral Premarin because of the blood clot and stroke risk, but still, I think it's good to see that, you know, Premarin's not such a bad drug, considering it's all we had from 1942 until about 1980 something. Anyway, and then here's LDL. You can see LDL goes down, all three, and they kind of do the same thing. So oral Premarin had the greatest reduction in LDL, followed by oral estradiol, followed by transdermal estradiol. So, but an important thing, look over here, triglycerides, that's what TG stands for. Transdermal estradiol lowers triglycerides. So when we think of lipids, it includes triglycerides and the cholesterol molecules. So I just think, obviously, the vast majority of gynecologists, they're not thinking about all these internal medicine, cardiology things. But that's why I'm just a little different breed of cat. And I like knowing the details because I've always ascribed to the aphorism, the devil may be in the details. So anyway, another one of your wonderful questions, if someone has not been on hormone therapy and is diagnosed with osteoporosis, can they start hormone therapy and will it have much of a beneficial effect for inhibiting the progression of osteoporosis? So I'm going to show you what osteoporosis bone looks like with increased fracture risk due to low bone density. Here's an osteoporotic bone on the right. And these are done, they're kind of cool because these are actual pieces of bone that they managed to put under a dissecting microscope and just show you what the architecture actually looks like. And you can see that the healthy bone over here has a lot more sturdy sort of girders within the entire area of the bone. And then the osteoporotic bone, looks, to me, it looks like gauze. So if we start, hormone therapy, and this is just what I want you to see, this is almost 2 years, this is weeks, this is 6 months, 1 year, and then we get up to a year and a half, and then 2 years. So you can see the femoral neck improves more with the higher dose. The blue is 0.1, that's a higher dose. Women on placebo continue to lose bone in the hip. Women on the low dose of 0.25 basically stay at 0, but their hip doesn't get worse. Women on 0.375, this was an anomalous population. But I'll show you the difference, and this is a huge difference. When we look at the spine, we see a much more robust building of bone. And that's because spinal bone and hip bone are made of different kinds of bone. And it's a sneaky thing, but most data is given for the spine because it's most impressive. And so the answer to your question, can you give estrogen to osteoporotic women and get improvement? Yes, not only do you halt their bone loss, but if you, for other reasons, let's say the woman's had a hysterectomy and dose, no problem. I have women choose, but many times women with very low bone mass will choose the higher dose because she's going to build her bone. These are over 2 years at a much greater rate. And so if low bone mass, risk for fracture is a great concern, yeah, we can use higher dose for a while. And then if other reasons she wants to lower her dose, sure, once she's out of the risky time, that's great. But here you can see on the femoral neck, you can see that the hip comes along. This is a better study. It was actually a much larger study. Hip comes along at about half the rate of the spine. This is almost 8, and this is 4. So this is normal. This is the typical thing. Bisphosphonates, guess what? Same thing. So raloxifene, all these other meds that are used, same thing. Much harder to get bone increase at the hip, but exercise, good diet, adequate vitamin D so that you're absorbing the calcium, and estrogen are a fantastic natural recipe for improving bone mass. Obviously, if a woman is already here, giving her estrogen may help her not become wheelchair bound, but for the vast majority of women who are already this osteoporotic, their risk of other medical conditions, again, she's got a walker. These are not the women, by the way, that come to my office and ask me for estrogen, but it may be this woman. And by the way, when this slide was made, because I was part of the conference on bone education for gynecologists, this woman was 65. In that, I mean, it kind of breaks your heart when you look at this woman is 50 in the kind of mock-up. They didn't write it down, but anyway, so just to let you know, the attitude towards women progressing like this, oh, this is normal. Yeah, women, yeah, they wind up frail, fragile, walkers, wheelchair. No, we don't need to go that route. If when entering menopause, one puts on sudden weight in the belly and breast, can getting the correct dosage of hormone therapy help reduce the new weight gain? Yeah, along with good diet and exercise. Yes, in fact, I just saw a woman, classic, 55. She's still kind of perimenopausal, but she's had 2 periods in the last 18 months. And she's gained, for the first time in her life, belly fat. So I gave her the reality check. Fortunate for her, she's 5'8". So, okay, that's lucky, because the taller you are, the more likely it will make a significant difference. It's about 75 calories a day for a woman that height that she will burn off if her hormones are adjusted appropriately. So giving her a healthy level of estradiol and also checking her testosterone and making sure they're balanced. She'll build lean body mass, she'll build muscle, and not just the biceps, triceps, but the big muscles in your legs and your buttock. Those are the big calorie burning muscles. So that's why Pilates teachers, you get your women strong exercise, they'll have more of a muscle building or anabolic response with those hormone supports. And so she can expect, if she's doing everything the same, that she would lose about 7.5 pounds per year. Well, for most of us, that's way too slow. So we'll do what this woman chose. I just saw her as a new patient today. She's choosing to diet, the 4-letter word I hope to never, ever do again, but she's going to go on a calorie restriction diet. She's done it before, 800 a day. That's a starvation diet, but she's motivated and she wants to get the weight off, and then she'll keep it off because then she'll probably have much more her normal basal metabolic rate that she never needed to diet before 5 years ago. So it's a small, but it's a sustained difference, like the magic of compound interest in the olden days when we actually had savings accounts that grew. But anyway, it's a very real thing, but it's a subtle thing. And I will admit, when I was younger, I just thought women, as they got more financially set, they were drinking more wine and probably eating out more, and, kind of ingesting more calories. Then when I saw the similar thing happening in my really disciplined patient population, I realized, no, that there's that effect of inadequate hormone balance. Since your question number 6 was, what is estrogen dominance and is it a real thing? So it actually comes from the world of fertility evaluations. And I thought it was a Marin County thing. It turns out it's sort of a naturopath, chiropractor thing. But as our ovaries age, they may be less robust in producing progesterone after ovulation. So, quote, estrogen dominance is a real thing. And it can interfere with the ease of getting pregnant. But more importantly, I've seen so much lab work in patients, done by other practitioners. Anytime you draw the blood between when your period starts and ovulation, you're not going to have any progesterone. So I have seen pitiful diagnoses of estrogen dominance when it was just the normal time of the cycle when we only have estradiol present. So that's why I hate that phrase, because it's misleading. On the other hand, I like to emphasize that it is the reason that we do see an increase in uterine cancer in the menopausal transition, when in fact the quality of ovulation diminishes. So I don't want to debunk it totally, because estrogen dominance, if you have ample estrogen, no hot flashes, vaginas normal, juicy, healthy, well, and you haven't had a period in, say, 8 months, and especially if you're overweight, and if your average blood sugar is high, and if you have high blood pressure, those 3 risk factors added to, I feel fine, I have no hot flashes, I'm going to get an ultrasound on that woman. I'm going to probably sample her uterine lining, because almost always it's overgrown, and maybe she just hasn't had the abnormal bleeding yet. So those 3 risk factors, hypertension, high blood sugar or hyperglycemia, and overweight, are where we see a significantly increased risk of uterine cancer, endometrial lining cancer. Okay, so that's what I want you to know about estrogen dominance. I love the questions you all ask. Great questions. This is a very old slide. Look at the years in which this data was collected, from 1990 to 2001. So I put this slide together and used it in a talk in probably 2002 to refute the Women's Health Initiative scare that came out in 2002 about estrogen, ET, estrogen therapy, hormone therapy. So these are all observational data. So, clinicians have been following relative risk of death for a long time. So for breast cancer mortality, in general, you can see if less risk is on the left-hand side of the slide, looks like the women on estrogen compared to women on nothing, which is this line down the middle, 1, 0, they kind of look like they die less, right? So this is what I didn't show you last time because I wasn't doing the deep dive to show you the data, but this data existed for many years and was discounted intellectually because these were not randomized, double-blinded, prospective clinical trials. This also came out, here's the reference, Zandy was the first author, Journal of American Medical Association, 2002. This actually was published in November of 2002. Now, if I've hammered anything in these talks, it's that the Women's Health Initiative came out in July of 2002. So July 9th, we will have the 20th anniversary of what I consider Menopause Hell Day, because everybody took this very simplistic, incorrect information, and we can see that media is not necessarily reliable in reporting, and also a lot of doctors and people who are invisible behind library stacks and universities got to have their day in the sun. But this is an Alzheimer's disease risk study. And it shows, just to show you, this is men down at the very bottom square. Right on top of the men who are the women who used hormones the longest. And then here are women who used estrogen for 3 to 10 years. And then here are women who used estrogen less than 3 years. And now the highest group, again, this is an old population, and that's why it's kind of cool, because it's looking at how things really were. Here are women who never took estrogen. So clearly, you don't have to be a rocket scientist. You can see, the women that use hormones the longest, they kind of have the lower incidence of dementia like men. And women who didn't use it, they have a lot more. So I promise you, this is not what clinicians who actually see patients think about. I just thought I'd include, since we're talking about the brain, what a hot flash looks like. So here's a woman who's on plenty of that, horse estrogen, conjugated equine estrogen. And what we're looking at here is all this kind of, it actually came out kind of brownish in the slide, but it kind of looked reddish. This is blood flow. And blood flow in the brain is a good thing. Brings nutrients and removes waste products, just like everywhere else in your body. Here's what a hot flash looks like. Not good. So, this slide is very old. This was 2000. So it breaks my heart. For those of us who have followed the neuroscience, it cannot be good for your brain to have a hot flash. So the advice to just tough it out, 85% will go away, is not good advice. Is there a relationship between estrogen deficiency and hypothyroidism or chronic fatigue? I said, no, not by the medical literature, except all three, hypothyroidism, chronic fatigue, and estrogen deficiency, are more common as we age. So it looks like they're associated, but estrogen deficiency does not cause thyroid failure. So there's not a higher incidence of hypothyroidism in women who are not on estrogen as compared to women on estrogen. About 11% of us, in fact, will have hypothyroidism develop usually by age 50. And you can see TSH, thyroid stimulating hormone, sort of creeping up as the gland production fails, just like follicle stimulating creeps up as ovaries fail to produce estrogen. Where we can research and direct clients to get accurate information on hormone therapy. So I gave you very straightforward, simple answer here. Although I wish I wrote the menopause.org website for women, but if you go to the consumer side, menopause.org, you can also find a North American Menopause Society certified menopause practitioner. So NCMP, and you It's a drop-down menu, very simple to use. You put in your zip code and how far you're willing to travel, and then you'll find a practitioner. And it's neat. I do this often when patients move. I had a patient move to Atlanta. So I looked up to see who I know in Atlanta who's a NAM certified practitioner. And of course, we all go to the menopause meeting. So, there are several thousand of us, but over the years, oh yeah, I remember meeting her. So anyway, it's a nice way to get reliable care. Very few are as, crazy passionate as I am, but still you'll get good, responsible information and also clinical care. The book Estrogen Matters, it was in our slide set last time by Avram Blooming, who's a cancer specialist at USC, specialized in breast cancer, and Carol Tavris. And then the more recent book by Lisa Mosconi, X-Brain, her first 20-something pages are all about the benefits and importance of estrogen in the brain. And then lastly, I mentioned once again my little pocket guide, which really is a one-night read, but it's very evidence-based. And even though I wrote this, published in 2010, it's just as true today. If I'm begged to write another book, and I do an update of a guide, I'm only going to do it if somebody says, I want to be your publicist. I've got connections, because the time it takes to even write that little book, it's a huge devotion. And I just am not a PR person. I see real patients. So, these wonderful gems languish in a Kindle version now. But anyway, the information is there, and it's the truth, and it's evidence-based. So last thing, Relizen. Yes, I do have familiarity with Relizen. I have some samples in my closet right here in the office, and it is rather remarkable. It is Swedish flower pollen extract, exactly as this person wrote in. It does help with hot flashes, fatigue nights, West irritability. Has no soy in it. And the fascinating thing, which they don't have a label for this, it really is FDA approved, by the way, and you buy it directly from the website. You don't need a prescription. What's fascinating is they also did a bone density study with a significant number of women. I think it was about 50 women, and they followed them on Relizen. So it does have an osteoporosis prevention bone effect. It was interesting to see that data. I saw the data because the rep who came by had it in her computer. And it may be on the website, I don't know. But yes, Relizen is an over-the-counter product, and it is excellent for hot flashes. My concern is I doubt within my lifetime we will have solid information that says Relizen prevents dementia, or Relizen helps prevent heart disease. So those are the slides I made for you all. And of course, I have a ton in my computer if we need any more. But I think that I'd rather just open it up to questions.
I had a question.
Uh-huh.
For a woman, I'm 51 years old, and I just recently had my hormone levels checked, and my doctor said there wasn't any problems, but I don't know that that's true necessarily the way they look at it. So is there any disadvantage to starting any estrogen or medication hormones before you're having menopausal, basic menopausal symptoms?
Well, I would actually turn it around, and I would say, in fact, there's ample neuroscience data to say it's an advantage to give yourself at least a low dose support continuously. Because from a brain standpoint, and the best data on the brain comes either from research labs or looking at large groups, like in Denmark, when to enter the Danish randomized double-blinded prospective menopause hormone study, like our WHI, in Denmark, you had to be within 9 months of your last menstrual period. So I don't wait for women to beg, borrow, and steal to get hormones. What I do think is important is number one, are you having nocturnal awakening? Do you sometimes wake up 2:30 or 3? Kind of a little, maybe a little bit more. Yeah, go to the bathroom, but you're really alert. You're really awake. That's classic estrogen deficiency in the brain. Transient. It goes away. When does it go away? It goes away about, 5, 6, 7 days into your period. So that's a symptomatic woman. And that's why I decided to take my information to all of you, because you shouldn't get this little pat on the wrist. You should get good information about not seeing hot flashes as just one of those things. As you saw in the brain flow image, it's distress up there. So yes, if you're having that, Anne, I would definitely, and the dose varies. Interestingly, 0.025, little teeny baby dot. Maybe next thing we do, I'll have my dog and pony show and I'll show you all my different products. But a very low dose of estrogen, interestingly, as a background, may be ample. It will make almost no statistical difference in your total estrogen exposure. Because remember, around ovulation, in fact, perimenopausal women often overshoot because their follicle stimulating hormones so high. But it's at these crucial days or, the week before, the week of your period. That's generally when women are most dysphoric or bummed. And it's also when, oh yeah, my period is probably going to come any minute. You can kind of tell by your breasts. So that's a symptom. And 025 patch often sensitizes the ovary to the FSH signal. And so, in fact, you're less naturally estrogen deficient. Your ovaries sort of perk up. And often it can help regularize your cycle. I have lots of women who their cycle starts to shorten. And sometimes just putting on the 025 patch, their cycle goes back to closer to 28 days. And similarly, the woman that is having the period every 2 to 3 months, her cycle may come back to every 30, 35 days. So it's interesting. I always start very low in perimenopausal women because, why take more than you need?
Thank you.
Does that answer your question?
Yes, thank you so much.
You're welcome.
Hi,
Roberta?
I'm Roberta. I have a question. And I'm sorry if some of this is a repeat from last time, but I had a virus last time, and so I don't even remember what I asked. I've been on estradiol, topical gel, and prometrium for more than 10 years, and it's been great. Bone density, great, whatever. Okay, so recently I was diagnosed with ADH, borderline DCIS, and a papillary lesion. And, they did a vacuum extraction on it, whatever, but I was told that I really needed to go off of the HRT, especially the progesterone. And I'm a little freaked out because I'm very small boned. My family has high blood pressure and high cholesterol, and I have some vascular issues. I have spider veins and whatever. So I asked about the Relazin or whatever however you say. So I'm just wondering, is there any way around this? I mean, I get an MRI again in August to see where we are. But if it's clear, I'd really like to go back on my HRT again.
So I'm going to show you. So I put some of this data in my phone just to sort of show you. So the orangey upper is basically Prem Pro. The dark blue lower is Premarin or estrogen alone. And I show you that because what is on this slide is the incidence of actual invasive cancer at 22 years is reduced in estrogen users. The line up here, the 0 or the 1 line, that is women on nothing. What's crucial is the longer dotted line. That is actually the data of death from all causes, which in fact, if you look at the units over here, it's reduced 50% at 22 years. So that's the data for women who've actually had breast cancer. Why does no one know this? I got that from the Journal of American Medical Association, over almost a year and a half ago. had to go online to see that particular data set.
Mhm.
That's not normal behavior for a clinician seeing real women in the office.
Yeah, well,
Like-
this is UCSF and it's,
Oh, yeah.
really
No.
the doctor there and
Of course. Yeah.
it would
So
be,
here's what I would say specifically for you, Roberta. You are the master of your body. You know your total well-being is not being optimally served being off estrogen.
Mhm.
Now, this is a bold statement, but I'm the doctor that holds the hands of the women for whom I prescribe it, whatever. If and I have a patient right now who had ALH, atypical lobular hyperplasia, about 12 years ago. Now she's in her late 60s and she has a micro focus of DCIS picked up on a mammogram. And so on the 18th of May, she's going to have a wide excision.
Mm.
She's going to be fine. Now, we knew she was at higher risk for having another lesion.
Mm.
That is true. But her risk of death from all causes is lower, just
Mhm.
like that data set. So the tricky thing is, I'm the doc who looks at your heart disease risk, your cognitive decline risk, your enjoyment of life, your mood, your sexuality. I see all of you. That's not normal in our culture. We're very siloed. And I do battle, I'm a UC product. I know these people, they know me. I mean, I don't think they hate me, but I'm a fly in the ointment because that's not right.
Hmm.
And the thing I've said in my talks to OBGYNs is when your patient is very demented, she doesn't come in for a GYN exam anymore. So we don't see the failures to thrive by
Mhm.
virtue of our omissions. The more important example, which is much more common, is the osteoporotic fracture woman. I mean, I have special tables that go up and down and back and forth, so I can see the referrals from the orthopedist for women with all kinds of, medical, physical problems. That's also not normal. So I do see other people's diseases of omission. And so I have a very, very strong opinion about the whole woman being served. And my mother had both, and again, being anecdotal, terrible, but I watched it happen. She was the queen of natural, terrible osteoporosis, terrible dementia.
Mm.
The last decade of her life was just horrible. So not to say I won't get dementia, I won't get osteoporosis, but I'm doing everything personally that I preach.
Yeah.
And here's the other data, I mentioned it last time. 81%, this is data from 2 years ago, canvassing OBGYNs in a study. I don't know if they were paid for it. They didn't ask me, I wasn't in the study, but they canvassed OBGYNs across the US. 81% of menopausal OBGYN women are on estrogen therapy. 18% prescribe it for their patients. Now, to me, that's an ethical lapse of a culture of clinicians.
Mhm.
If we think it's good for us enough that we take it, why are we not taking the time and changing the healthcare system to take better care of our patients who trust us? So look at this. You've just invested an hour of your time to hang out and talk about stuff, science, but you don't get an hour of your doctor's time or your nurse practitioner. And honestly, we've just had a rather major event with the Roe v. Wade, the Supreme Court. Look, women, let's mobilize. What happened to women's lib?
Yeah.
I think I said last time, I was really not a feminist. I went to Cal. I want to go to medical school. I didn't do drugs. I wasn't, throwing rocks through the administration building. I protested peacefully. I'm part of that group of women that got Roe v. Wade. We showed up at marches and, letter writing campaigns. But, I take care of a lot of young women who are incredibly passive. They pretty much had stuff handed to them on a, women's rights silver platter. So the erosion of rights, we can see this is bold. I would say the same disregard of your value is reflected in our, meaning the medical culture's manner of taking care of menopause. The residency programs training today, 2 to 3 hours of menopausal medicine is included in the training program. So you're seeing, especially if you have younger doctors, and I used to torture myself and go to the UCSF sponsored, midlife and beyond programs, CMEs, just to see what are they saying. And I just had to stop going because their average age of the young faculty who were giving these talks was about 35. Okay, how much passion would the average 35-year-old have? The average 35-year-old, maybe their mom is, 60. Mom's not 80. So it's this part of aging that, I look at longevity. What we want is health span, not lifespan. And so we have to, meaning you and I as women, we have to put the energy in. That's Pilates, mindfulness, good nutrition, plenty of water, and make sure that we understand why we think something is good for us. And to be clear, that is my experience. My experience is my arthritis, my overuse of my knees is much better when I'm estrogenized than when I'm not. I mean, obviously, you're looking at somebody who's not spent more than those 6 weeks just so I could experience a few hot flashes and feel sympathetic. But, that was it. That was enough education for me. So I really have not had the arthritis and stiffness of normal.
So if I'm off of this for 6 months, am I going to have an issue going back on? And you keep saying estrogen. So would I just be on estrogen? They measured and it was, I have estrogen and progesterone positive. With estrogen is
right,
just
of course, because guess what? All of our healthy breast tissues, ERP, are positive.
Mm-hmm. So would I just be on estrogen if I wanted to do something like that?
So the sexy answer is the Mirena IUD to keep the uterus thin. That's it's not metabolically systemic. Mirenas really are a local only measure. You can't measure anything in a clinical assay. It doesn't change liver functions. It doesn't change clotting factors, etc. So it's kind of how women with a uterus can live life systemically on, quote, estrogen only. Interestingly, the data out of France, that's the best data for use of transdermal estradiol and natural bioidentical progesterone by mouth, or women in France take the progesterone vaginally about half the time. Anyway, so that data is actually pretty powerful to show it does not adversely affect the outcome of breast cancer. So it's kind of neat to know that that is also true.
Okay. Thank you.
You're welcome. We're very sociocentric in the United States. It's funny. Somehow it has to have like our brand on it. It has to come out of Johns Hopkins or, University of Oregon or Harvard, UCSF for us to believe it. Can too much progesterone cause menstrual bleeding after menopause? It's kind of hard to get too much progesterone because it's a pretty weak actress. But yes, intellectually you could. If the lining gets super, super thin, it becomes unstable. The most common cause of irregular, funky bleeding in women on continuous progesterone, not cyclic progesterone, but continuous, honestly, is abnormal anatomy. Like maybe she has a polyp, maybe she has a fibroid, maybe she has adenomyosis. So I would definitely encourage you to ask for a pelvic ultrasound. It's funny, Kaiser almost never does a pelvic ultrasound, but if you ask for it, they will. An increase in estradiol is possible in almost any age of menopausal woman. The ovary can have kind of like a solar flare and just transiently make more estrogen. And then when that goes back down to its baseline, not much estrogen, yeah, you can have a little withdrawal bleed. But again, I would never say, oh, it's probably just a little, I always investigate that, you know, and I'm not a panic artist, but I'm diligent and thorough. So unscheduled bleeding needs to be investigated to a very thorough, complete conclusion. Okay, I think that pretty much answers.
There was one more, if you have a minute.
Sure.
There was one earlier on about the product you had mentioned early on. I think you said Jenna, I think it was, in the very beginning. You were talking about
by Bijuva, Bijuva. Bijuva is bioidentical estradiol 1 milligram and 100 milligrams of progesterone in one little pill. So I love it because guess what the most common reason for abnormal bleeding in fact is user error. Oh, I forgot to take my patch and change it. So when your estrogen goes down, you have a little withdrawal bleeding. Or the other, oh God, I forgot to take my progesterone this month. And then I was taking a trip and I didn't want to have my period on the trip. So I see women who, you know, I kind of haven't had I can't really remember the last time I had my progesterone cycle. So user error is the #1 reason. So anything that has both together, like, you know, you're not going to forget because your estrogen relieves your symptoms. So you're not going to forget that. Anyway, so Bijuva by Therapeutics MD is easy product, works really well. And again, if there's one copay, it's cheaper. That's not fair, but that's the way it is.
One more was the cutoff age for HRT. I think you answered that last time, that you were going to go to your grave with the patch on.
Mm-hmm.
So that resonated with me.
And again, if you look at men with their steady on, I showed you that slide, they're never going to take their testicles off because they're tired of all those hormones. And again, if we all died by 50, fine, no problem. That's not what's happening. Because of public health measures and medical advances, immunizations, here we are. So, you know, I always love that, give me liberty or give me death. I'd like a vigorous body, please, a good mind with which to pilot my life around and be of service to people and the planet until maybe pretty close to my last breath. That's what I want. So, you know, I'm putting my oar in the water and I'm rowing, and I love the fact that I'm a woman, but I gotta buy my hormones. That's just the goddess's truth.
I have one last question.
Okay.
I thank you so much for this presentation and this information. It's so valuable for so many of us. I'm wondering about access though for, I have Kaiser, and will it work for me to go to my gynecologist and say, this is what I want?
Yeah.
Okay.
Yeah. And the standard at Kaiser is 0.5 patch, 100 milligrams progesterone, no questions asked. And they'll give them to you at the same time.
Okay. What about for folks who are maybe on Medicare or don't have direct access? Are there doctors that they could get for treatment?
Chris, I think you don't mean Medicare. I think you mean like Medicare, Medi-Cal, Medicaid.
Yes.
Mm-hmm.
Thank you, Toby.
These are all approved. You have to have a clinician that understands and prescribes it. Medicaid is easier because, you know, for younger women after 65, I mean, my office staff battle to have our prescriptions approved, and I won't bore you with what a hassle that is, but you just have to have a clinician that is supportive.
Okay.
So
Thank you.
you're so welcome. All right, I'll see you all in a month.
See you all in a month. Thank you guys so much for being here.